topography guided photorefractive corrective.
Good afternoon. My topic is long-term refractive and visual outcome after topography guided photorefractive keratectomy, PRK. Laser vision correction is now established as safe and effective treatment for refractive error. It is associated with excellent visual outcome, improved quality of life, and high patient satisfaction. Rapid advances in technology and innovation have increased the range of refractive surgical options available to patients. Surface ablation uses an excimer laser to expose and remove the corneal stroma after removing the corneal epithelium. It has improved safety, especially in patients with high myopia and thin corneas. Topography guided laser ablation attempts to create more uniform corneal surface to reduce aberrations and while also correcting the spherocylindrical refractive error. The basic idea in topo-guided PRK is to target the excimer laser spots to flatten the steeper portions and to steepen the flatter areas by ablating around the flatter areas. Centration is based on the corneal apex and not on the pupil center, and thus it negates the angle kappa issue. We have studied the outcome of topography guided surface ablation in virgin eyes. The aim of the study was to evaluate the long-term refractive and visual outcome after topo-guided PRK. The study was a retrospective chart review. Data of all patients who underwent topo-guided PRK from January 2018 to December 2019 was collected. The data of their follow-up at 3-month and 2-year procedure were also collected. Inclusion criteria were age more than 18 years with stable refraction, central corneal thickness more than 460 microns with preoperative refractive error between -0.5 to -7, spherical myopia between 0 to 3 cylinders of astigmatism. Exclusion criteria included PACI less than 460, eyes with a significant dry eye, cataract, corneal scarring, keratoconus and other corneal ectasias, chronic inflammatory diseases, retinal and optic nerve diseases, and systemic conditions including autoimmune diseases, pregnancy and lactation. Patients who met the above criteria who underwent topo-guided PRK and having follow-up of 2 years following the procedure were recruited for the study. The laser ablation platform used was an MEL80 laser system by Zeiss with CRS master treatment planning software. The patients selected for topo-guided PRK were those with PACI less than 500 with high refractive errors and low flat K values, which cannot be taken for standard procedure. The outcome measures of interest are uncorrected and best corrected visual acuity, manifest spherical equivalent refraction, sphere and cylindrical cylinder, each parameter measured pre-op, third post-procedure, 3rd month post-procedure, and 2-year post-procedure. Statistical analysis was done using Stata version 11. Mean and standard deviation were calculated for all data. Pre and post PRK values are compared using the using paired t-test. The data of 77 patients were collected. Mean age was 26.18 plus or minus 4.86. Paired t-test was used for analysis. The preoperative uncorrected visual acuity improved from in the logMAR unit improved from 1.11 to 0.12 at 3 months, and it was at the end of 2 years it was 0.34. Best corrected visual acuity improved from 0.13 plus or minus 0.15 to 0.09 at 3 months and 0.08 at 2 years. This is the spherical equivalent improved from minus 5.05 to minus 0.06 at 3 months, and it was at minus 0.05 at the end of 2 years. This is the comparison of preoperative and 2-year postoperative spherical equivalent in those patients. You can see this arm shows 70 out of 77 patients had 0 spherical equivalent. And this is a graph showing the preoperative best corrected visual acuity compared to postoperative uncorrected visual acuity in topo patients. And you can see in this 6-6 arm, you can see more patients are falling in this postoperative arm compared to the preoperative arm. Yes, there is a dip here that is due to the undercorrected patients. We had to undercorrect some of the patients, and that is causing this dip. Otherwise, all patients are getting even better than preoperative best corrected visual acuity. At the 2-year follow-up, more than or equal to 0.18 logMAR visual acuity was observed in 77.92% patients. The percentage of eyes having spherical equivalent within plus or minus 1 diopter achieved at 2 years was almost 97%, that is 75 eyes. At the 2-year follow-up, zero spherical equivalent was observed in 90% of patients. Topography guided treatment has improved outcome with kertorefractive procedures, correction of corneal higher order aberrations, high astigmatic errors, and anterior surface regularization for ectatic corneas. In a study conducted by Stulting et al., 249 eyes, it was found that the topo guided treatment showed good visual outcome with stability up to 1 year. Study by Husna et al. Demonstrated good efficacy, predictability, and stability of eyes undergoing topo-guided LASIK. It induced fewer higher order aberrations and less coma than wavefront optimized LASIK. Multiple studies have shown fewer higher order aberrations in topo-guided LASIK when compared to other modalities. With the advent of topography guided ablation, we can now offer patients not only freedom from glasses and contact lenses, but also likely improvement in best corrected visual acuity also. There were a few limitations in our study. Firstly, this was a single arm study and we were not able to make direct comparisons with other modalities like wavefront optimized or wavefront guided ablation. Secondly, we were unable to perform a subjective assessment of higher order aberrations as we don't have the facility at our center. Conclusion: topography guided PRK treatment produced excellent visual outcome in eyes with high refractive errors and thinner corneas. It is a good option for of laser refractive procedure for patients with high refractive errors and thinner corneas when there is no option for other advanced laser refractive procedures available. Thank you.